Thank you very much for joining us. This is Ventilation Matters number 7, and tonight we have a great team, again, of Jeff Shaw, Graham Acorn, Matt Coe, Patrick Tan, Ross Freeburn, and myself, moi. And tonight we're going to cover several different subjects related to mechanical ventilation. Initially, we'll talk about flow triggering. Then we will discuss the use of PEEP and the power equation, and then we'll look at different ventilator modes and the configuration that the clinicians might use to monitor patients while they're on those particular modes. So with that being said, let's get started. What I have here is just a basic high-level approach to flow triggering. And okay, there we go. So essentially, this is the inspiratory limb, expiratory limb. Q1, Q2 creates the inspiratory circuit, gas flows through. When we're first starting out, we calibrate the ventilator. Part of the calibration routine is to determine if leaks exist in the circuit, but also to look at the compliance in the circuit so we can compensate for the volume lost in the circuit at certain pressures. And then, believe it or not, we calibrate the expiratory circuit or the expiratory flow transducer to the Q1 and Q2 flow transducers that are there for oxygen and O2. And when that happens, we would expect that the flow coming down the inspiratory line would equal the flow in the expiratory line. And when a clinician or user sets, when a clinician or user sets flow triggering, then they essentially, the ventilator waits, and in this example, I've set a flow triggering of 1 liter per minute. 5 liters go down the inspiratory line. The expiratory transducer sees 4 liters. It assumes that there are no leaks and that the patient has demanded a breath. 1 liter is triggered or pulled into the patient's inspiratory line, and the ventilator essentially delivers a breath. So that's how flow triggering works. Clearly, there are issues that can occur, like leaks and the application of non-invasive ventilation. And these are actually advantages of flow triggering. We believe, early on, we believed that the work to trigger the breath was reduced by flow triggering, that it reduced the circuit rebreathing and the physical dead space. Again, if I could, it's very sensitive. Essentially, the gas is constantly flowing, so the dead space, truly is the dead space past the patient Y and the endotracheal tube, and of course the anatomical dead space. And essentially with free flowing gas, Catherine Sassoon showed back in the 90s that the trigger time could potentially be reduced in a properly set ventilator. So who are you? Who do you think flow triggering is indicated for? What patients are you definitely wanting to trigger the breath and breathe spontaneously?
Could I reframe? Oh, sorry.
So, Steve, our practice would be to leave the trigger on all the time, and would use flow triggering on as a default for all patients. That's what I think Jeff would be the same. I think that's standard throughout New Zealand and Australia now, to use the flow trigger on all the patients, based on perhaps poor knowledge, but an understanding that this is more sensitive than pressure triggering. And that would be on most of the time. I think it'd be very rare for us to turn the trigger off at all on our patients. Jeff, is that correct?
Yeah. I was
Yes.
going to I was actually going to reframe the question. Why would you not use flow triggering? In other words, you've got a better and more sensitive index, short of some sort of neural control. But my question is really, why would you want to go back to something which doesn't work as well? And So I'm really just supporting what Ross is saying, that we would use it on all our patients, unless there was something crazy. You know, there was, I don't know, maybe a leak in the circuit that we couldn't fix up, or we have had occasions with the old 840s that we had, that using the flow triggering sometimes allowed inappropriate triggering reasons I would never really quite figured. So I would put the patient in that case on pressure triggering. Well,
Yeah,
that's about all.
I think it is user related when we run across conditions where flow triggering isn't a better option. I guess I would extend that question though to ask, who are you allowing to spontaneously breathe? And then of course, what I hear is that flow triggering would just naturally be the methodology. But when you employ flow triggering in the newer products, there's an automatic baseline that's provided for you. With some of the older ventilators, you are required to set both the base flow and the triggering. So for an unskilled user, someone who doesn't know their tool, you could be ineffective with flow triggering if you were to set too high of a flow trigger level. Let's say that you were setting it to overcome a leak, the leak reduced itself, and now the patient has to overcome the gas that was previously considered to be leaking, in addition to their request before the ventilator would recognize it. So that might be, it's user it's user experience, and it's user settings that might present that as a problem. But if we can then talk about the who are you allowing to spontaneously breathe? COPD patients, can we generally make that statement that when you have an exacerbation of a COPD patient, that you would initially put them on a vent and keep them spontaneously breathing? Or what are the thoughts there? And then after the trigger, are you monitoring rise times? Is anyone monitoring rise times on their pressure-based breaths?
If we just fix to COPD patients, one of the things we're doing in our ICU is actually we tend not to put these patients on the ventilator. We certainly don't intubate them. We tend to use essentially BiPAP for most of these patients. And a lot of our patients have, because they're followed in the respiratory clinic, they often have fairly clear advanced directives about whether they would actually want mechanical ventilation or not. So it's not that common that I find myself with a patient with severe COPD on the ventilator these days. But in terms of spontaneous breathing, I suppose that most of our patients during their ICU run have some form of flow triggering, because we don't use just straight mandatory ventilation. Most are assist control. But we kind of determine where they are in their ICU journey before we start thinking about spontaneous breathing. And often in the very early part of their ICU course, we're actually trying to suppress the spontaneous breathing.
Okay, go ahead, Jeff. Were you going to say something?
You're very good. I flow triggered the conversation. I took a breath in, and you were able to sense it. It seemed like that anyway. Yeah, I think that a more important question is whether the patient should be spontaneously breathing before we even consider how they should be. Before we start considering triggering mechanisms, and that comes down, I think, to clinical judgment and trial and error. And I think, as was alluded to, there are quite a few patients where if we let them to try and breathe spontaneously, then they're going to get the patient inflicted lung injury, self-inflicted lung injury, whatever that's, P silly. And that is one thing which always concerns me. So I guess what I'm trying to say is that before that the issues to do with flow triggering or pressure triggering or how it works are probably a lot lesser of a concern than actually putting a patient on whatever form of trigger and having them spontaneously ventilate when in fact they shouldn't be spontaneously ventilating. So I guess in answering the question is, if we are convinced that it is a good thing to have the patient spontaneously breathing, and there's a whole debate is how we make that assessment. And I'd love to hear what other people's opinions are on that one. Then the flow, then the triggering which imposes the least work of breathing is clearly the correct one. So that's why flow triggering obviously is the choice of triggering outside of other more fancy and perhaps some invasive metrics to measure patient inspiratory triggering, if that makes sense. So I'd be quite keen to hear from others about how we make an assessment about the readiness for a patient to breathe spontaneously. Was that outside of our remit here?
That's perfect.
I think, Jeff, you're spot on, because one things I find I'm still learning is, or perhaps what I've realized through my learning is that I still don't have a good grasp of all the determinants of respiratory drive. And
yeah.
I think certainly during the early phase of critical illness, the respiratory drive can be so high that we do see this patient self-inflicted lung injury if we allow or pursue spontaneous breathing early in the critical illness. And one things we've found ourselves doing more and more is even being less afraid to paralyze for the first 24, 48 hours. During my training, I was taught paralysis is this big no-no. You're going to harm the patient. You're going to create problems with recovery, ICU-acquired weakness. But what we've realized actually is, if you look at the observational data, that doesn't necessarily play out. And for short periods, if we don't suppress the spontaneous breathing when they're very early in their journey, we actually think it makes things worse with the patient ventilator interactions and can actually create worse ARDS than you already have. That fits with everybody else's observations.
There's an anecdote.
Matt,
Off you go, Ross.
no, that's right. Matt, I agree with you. I think you say early on, but I think there may be a potential damage done during what we think was during the weaning phase, where there's still regional damage or consolidation, where the effect of spontaneous breathing may over-distend certain areas of the lung. I think the point which I think Steve's trying to get us to answer is, when is it good to move to spontaneous breathing? And I certainly don't know the answer to that. It's obviously different for different patients. But it's certainly, I don't think it's necessarily a time frame of 24, 48 hours, but I don't really know which parameter we should use to guide us. Is it oxygenation, or is it some other form of lung mechanics, for when we should be able to move from a very controlled, assist control, but a very controlled mode to a more spontaneous mode? And it must depend on the type of damage and the degree of damage. And I don't know which parameter people are using. So, but triggering, the amount of triggering that's required may give us an insight into how much work is being done by the patient, and that may be associated with damage that's been done as well. It's complex, but yeah.
I think I'd agree with you, Ross. If there was, and this is where we might be getting into mechanical power, but I guess an index that just says how much energy is impacted by the lung, be it through the patient's diaphragm or through the ventilator itself. And remembering that the diaphragm and the ventilator impact the lung differently. then that would probably give us better metrics to work out whether or not we should have our patients weaning. We need better metrics to judge the power or the energy dissipated during a breath by the lung, because that basically will directly transfer into some mechanical strain that will then impact on the lung injury. And as a result, are you still there? As a result, I think some objective assessment of that would be useful. What we end up doing, because we don't know how to do that very well, is that we just look at the patient. We just look at how dilated their pupils are and how much stress and how much sweat is on their brow. And the truth is that some of us are really good at that and some of us are awful. And occasionally you walk by a patient and you'll see them really struggling and the nurse is there looking quite indifferent to it all. And I think this is like the frog in the boiling pot analogy, is that patients will often slowly and progressively fatigue, or something happens to the mechanics of breathing and they begin to fail. But if you're the bedside nurse, you don't actually see this as an abrupt change. It's a very, very slow, painful one. And perhaps for cultural reasons, people don't speak out. And I think that is actually a big issue, that we do let patients struggle on and struggle on and struggle on because of false beliefs that paralyzing is bad. And we don't have any objective metrics to allow us to infer lung injury by the process of ventilation. I was going to say one other thing, that oftentimes I would paralyze a patient and I would just need one dose of relaxant and then not have to paralyze them for the rest of the, day. And I've often wondered, why is it that you can get away with just one dose of a muscle relaxant and the problem and all the desynchronous breathing and everything goes away? And I think it's actually quite simple. When you paralyze them, you suddenly remove all the muscle energy that is causing CO2 to be released, which has to be obviously dissipated through the lungs. And in doing so, the body's metabolism drops, and you're then able to control the CO2 much better than you can when someone is not paralyzed. And CO2, of course, is a massive driver, a massive respiratory driver, and also stimulates all your catecholamines, and that then positively feeds back and creates more increase in metabolism. So I think what we have is a vicious cycle, things winding up with positive feedback, which causes the patient to breathe harder, CO2 goes up and they get more and more distressed, and finally they crash. At which stage, what we do is we sedate them and or paralyze them. And I think that is a pretty standard picture right around the world, I suspect, of how we ventilate patients and how we manage them. And I would suggest that that's actually a really bad thing to do. The question is, how do we pick that up early and intervene before that badness happens?
So if I can bring up two or 3 points to go back to understanding it, is the patient comfortable or are you not watching? Apart from obvious things like minute volume and or respiratory rate, we have measurements such as the PTP or P0.1. The ventilators can be configured to measure that. It's actually telling us a lot about patient comfort or responsiveness. So that can be for COPD or any patient stressed out. And maybe we can cover that somehow. But also, too, just to go back, Jeff, to the muscle relaxant, when we used to work with Keith Hickling, he would often use a muscle relaxant to so-called reset somebody. Patients charging away, give them a muscle relaxant, settle them down, let the CO2 go back to wherever it should be. The brain goes, this is normal.
Yeah, that's what I'm talking about. Yeah. But I haven't seen that described.
Just now.
But it's exactly what I'm talking about. It's just what you sort of pick up over the years. And it seems to work quite effectively.
Well, I thought, Ross, didn't you and Keith write something on this a long time ago or some time ago?
Yeah, we wrote a couple of things on. One is about the effect of spontaneous breathing on and how damaging it may be even late in the piece. But the other thing was we did some work on muscle relaxants and couldn't demonstrate any benefit of paralyzing, but that was in the short term. I think one of the problems we have with all this stuff is we paralysing patients for short-term gain, which is quite reasonable in the acute setting, but we're talking about longer-term benefits to do with a effect on ARDS and therefore on long-term outcome. And we can't see that. And so the benefit we get of synchrony and the patient not being dysynchronous is obviously beneficial to us in the short term. How that translates to benefit in the longer term is somewhat different, because we assume it's through lung mechanics or doing something to reduce the damage. I was going to say, Jeff, one of the things that happens, of course, in that quite short period of time, if it's an hour or 2 hours, is there's a resetting at the CSF level, because it's not actually CO2 that causes the respiratory drive, it's CSF acidosis. And given a moderately short period of time, if you have reasonable kidney function, there will be a change in the bicarbonate balance in the CSF, and therefore your respiratory drive is decreased. And so getting over that may be helpful. So that's why you're 1-off, 2-off doses of paralysis and not needing to continue for a long term may be beneficial. It's just one of the mechanisms by which it may work. Of course, if you give something like 300 or 400 milligrams of rocuronium, one dose is enough for a little while. So
That's true.
But if you, I agree with you. A lot of the time we give 1 or 2 doses at the beginning, and by the end of the evening, you don't have to paralyze patients at all. They are quite happy to sit on the opiate and sedative. I think that it's something worth studying. I don't know how to study it and what the answer would be, or what the question would be to start.
Yes, I think that I take all the good advice over the years, and my own practice has modified in that I am now much more aware of the need to step in early and bring about muscle relaxation. And I have noted that the changes in the mechanics as well as the acid base does come through quite rapidly. So we have tried to use this practice now in our unit, but we are still a little bit unclear how, because perhaps we are not observing or monitoring the things that should be done, as to when we should try to come away from that position of muscle relaxation in order to allow the patient to resume their spontaneous efforts.
So Ross, did I understand you correctly that it's a reset or a recovery period, essentially?
That if you expose a patient to high CO2s acutely, there's a huge respiratory drive. And over time, the bicarbonate levels in the CSF change, and therefore there'll be an adaptive process that what we call compensation in blood gas analysis is in fact a buffering, increased buffering. So the effect of CO2 on the CSF pH decreases. And so that over quite a short period of time, that drive will be diminished. There'll be a reduction in drive. All other things being equal, which of course they're not. There's a number of things. It's just one of the many effects that occurs. The chemoreceptors inside the CSF that detect changes in CO2 are altered. Their sensitivity is altered by exposure to high carbon dioxide and then to bicarbonate change. So,
yeah, you could liken it. I'm just thinking of an analogy. I remember when I was a student having a dental friend of mine who said, "Hey Jeff, do you want to come for a run?" Now I don't run. I'm about as unfit as the next guy. But I kind of figured when I was young that I better run now because these guys are only going to get fitter. And so and it was only going to get worse the next time or the next time. So I went for this run up the Northern Motorway in Dunedin, and those from Otago will know what I mean. It's a fairly steep incline. And I nearly killed myself. And my friend was well ahead of me, and there he was doing press-ups and God knows what else. And I sort of got to the top of the hill, huffing and puffing, and thought I was going to die. And he said, "Oh, great, good, you're here now." And he took off again. And I thought, shit, I don't get a chance to even relax here. And I think recovery and the ability to rest after stress is actually really important. And I suspect that what happens is when our patients are in fact in an awful situation, they're like me trying to run up the Northern Motorway. And by giving them a relaxant, you are giving them an opportunity to rest, and you may not need it for very long because their body has already partially compensated through the mechanisms that Ross is talking about to increasing CO2. So just giving them a rest, reducing the CO2 production, will get them below their threshold, and then suddenly all of that distress and whatnot goes away. So that's what I've always thought about that when I see my patients struggling, and realize that the need for rest and recovery is actually extremely important. It probably also, and this is off topic a bit, if you don't ventilate well, you don't sleep well, and if you don't sleep well, you have more delirium. And I suspect there will be a relationship, I'm sure somebody will tell me there is one, it's been well published, between delirium and some metric of bad ventilation, call it dysynchrony or need for muscle relaxants or need for more opioids or whatever. Or maybe no one's done that work, but it would make sense, wouldn't it? If you've got fractured sleep, you can't sleep because the ventilator is not quite tuned to your needs, then you're not going to be a very happy person. You're not going to be able to think straight.
So maybe one of the worst modes for this is SIMV. We put them on, we think this mixed mode of ventilation is a good mode, but people don't alter it. They keep them on like a rate of 8 so that the patient still is working hard, and they don't think it's nighttime. Well, we should actually increase the rate. And so the patient is always stressed out the whole time. I'm not talking about the synchrony, just the patient being flogged, the diaphragm working and working and working. On one hand, they're fighting the ventilator, but they're just not being rested. What do you think?
Well, I've always had a problem with mixed modes. Hence, assist control sounds more, sounds better intuitively. But, how can you possibly adapt? How can the human body adapt to a changing ventilation every second breath or every third breath? So this breath will be controlled, this will be controlled, and oh no, you breathe them within a certain window, we're going to give you a totally different algorithm. We're going to put you on a pressure supported breath. You can take as much air as you like. And I suspect that having that set up probably means that you can't adapt to it in any way, in any case. That probably makes things worse.
Yeah, Jeff, there is data showing that the feedback from SIMV is the brain is too fast for the machine, and that you don't get the synchrony you expect. So you don't get the enhancement you'd expect with having synchrony. One of the issues with the respiratory drive is we tend to, but I don't know if we do this deliberately, but often patients are ventilated down to a CO2 that is slightly lower than you'd expect for the respiratory drive. If they had normal bicarbonate, normal acidosis, we often ventilated people with CO2s in the high 30s, which takes away their respiratory drive. And that helps with our synchrony. It gives us a perception that the patient isn't taking a additional breath, and therefore we're comfortable. That may not be the best thing for them, but it makes us happy because they're lying on the ventilator and not struggling against the machine. And we often, when you're trying to wean patients, you often will have to wait for a few minutes for the CO2 to rise to a mid-40s to allow them to take their first breath because there's no drive there. Now, whether that is good ventilation or not, it looks good from the outside. We've been taught it looks good, but with that additional power that we do for ventilation is actually beneficial for patients. I don't think there's any real data on that. I think it could be that we are doing something artificial that makes them, paints them up to look a very pretty color, but doesn't necessarily make them better because we maybe doing more damage in doing that, just subtly. It's the same with the spontaneous breathing with levels of pressure support, having them look at a regular, large tidal volume breath, which we've associated with being healthy. That may actually be harmful rather than having small panting breaths, which we've always associated with being bad. It's just a thought that maybe our parameters that we're looking at in the short term which we've associated with badness when patients aren't ventilated, are not necessarily harmful to patients when they're being supported.
Mm.
Just a thought.
Just to come back to what you started off by saying, Steve, on triggering, we know that all machines are not the same. They don't all respond. We say they got flow trigger. It means nothing, right? But we are assuming now that the new technology, if you can measure, for example, sensing proximally, anything at all, there's actually minimal difference really in some of the new technology between the trigger of a pressure trigger to a flow trigger. The important point is leak, of course, getting that more stable baseline the whole time is important. And just to add one more point, I think Jeff was saying about flow trigger and some issues with it. The only time I've seen issues with flow trigger is obviously the flow isn't correct, the correct flow setting. If it's too hot, if it's too sensitive, and you might have tube compensation set. And then it's just like a machine gun sometimes too, that it's just, you're dealing with resistance plus the flow trigger is too sensitive. So, you know, when we start talking about tube compensation, then you think about your flow trigger, it's a different game.
Well, I don't know about you guys, but I was taught to drive the flow trigger down to the lowest level where you would see some auto triggering and then back it off slightly from there. And that was kind of the way of the world back in the 90s, 80s and 90s. And you're absolutely right. In fact, I cannot remember the authors, but I was reading an article the other day that showed that they analyzed many of these ventilators that are out there that claim to have flow triggering. And it was shocking that only 3 out of 10 of the ventilators they analyzed were actually doing what they were saying. And whether it was related to calibration of the system or just plain not doing what they said. So that was a bit shocking. The good news is if you were using a ICU quality ventilator, that those were among the ventilators, you know, the brands we know, were among the ventilators that were actually doing what they said. And that was
an observation I've made recently, and sort of channeling Marcelo here, and that is to do with this idea of increased lung strain in the peridiaphragmatic regions of the lung, and the concept that he introduced of penduluft, that is that air will flow during inspiration or towards the end of inspiration from the more compliant parts of the lung to the less compliant parts of the lung at the very end of a breath. And in fact, if you look carefully at patients, you can actually detect this. And I hadn't really thought to do this, but in fact, it's not that hard. So what I'm specifically looking for is a rocking of the chest, anterior chest wall. So when you've got someone who's on, let's say they're on some form of duopap or bilevel, I'm thinking some pressure controlled ventilation. And they're breathing in, first of all, the more compliant parts of the chest start to inflate. And you see initially the anterior upper chest expand, rise in the bases of the lung. And so if you think of that logically, the only way you can explain that is that there was a part of the lung that was, and I'm going to use an engineering expression here, that had very high elastance at the bases. What the diaphragm does is it adds negative elastance and it makes that part of the lung more pliable, and which is why gas now flows down to the bases. But in doing so, you've got a lot of lung strain, and that causes the injury. So coming back to our question that we posed earlier, if I see this rocking motion of the anterior chest wall on a patient, and I'm thinking to myself and imagining penduluft within their lungs, I'm thinking they're probably not in the right spot to breathe spontaneously, because I cannot know how much injury they're inflicting to the basis of their lungs. Does that make sense? So I just thought about that as we were talking. I'm sorry, I've gone back in time.
I think that's very important, because I know Yoshida has shown that the the pendulum movements, some of those air movements can be up to 15 mils per kg ideal body weight. It's quite injurious, actually.
Yeah, on a regional basis, they are, aren't they?
Yeah.
Overstimulating some alveoli. Yeah. So, it's interesting. I think isn't that the difference between what is a true static compliance and a dynamic compliance? Is what you see initially at the end of inspiration is the dynamic compliance during the first part of the therapy hold, and that's your dynamic compliance. And after all air movement stopped in the lung, which is what Jeff's describing, after pendulum, you're going to get a different compliance, or Jeff's term a different elastance that changes. So that's, in a way, it's the true static compliance and the difference between dynamic and static compliance that makes a difference here, because and it's that over distension of those alveoli that is probably causing the harm.
I think actually what's happening, and Marcello explained this, is that the lung isn't a sponge. In other words, the pressure distributions within the lung, there are pressure gradients within the lung, is what I'm trying to say. And so if you apply negative pressure at the basis of the lung, that negative pressure stays there. It isn't transmitted all the way through the lung. So towards the end of the breath, your diaphragm's still going. You've got this air hunger, and yet the ventilator's switched off. So what's happening now is the diaphragm is reducing the elastance, the stiffness of that lung at the base, and is now allowing the gas to flow according to redistribute according to the elastance, the net elastance within all the units of the lung. And so what you have is this uncontrolled and unmeasured, if you like, tidal volume that is effectively applied to those bases. But the thing of what I'm trying to say is that, all explanations aside, you can actually see this happening. It's probably something that's been looking at us in the face for years. We haven't really thought much of it, but it's really quite useful. And you see this in someone who's on, say, bi-level, duopap or whatever. You actually see this scalloping out their pressure curve with their flow starvation that they get. And I think that is an indication that probably if you have a lot of that, they should be breathing spontaneously, and maybe you should think about paralyzing. So there's a lot of work to be done. There's a lot of work to be done, and I think that we have a big knowledge gap. And I'll be the first to put my hand up and say I don't really understand it very well at all.
Steve, could you, just to move on, but you may be backwards, the work done against triggering a machine when you're on flow triggering is measured by the area under the curve, or below the curve, I guess, the area under the curve of the pressure waveform. Is that correct? Is that how you can measure it?
So you're saying the work to trigger is the area, the pressure time underneath the baseline of PEEP or
whatever. Yes, under your PEEP.
Yeah, that's the way the ventilator uses it. In fact, the old 7200s, you would modify the baseline to the PEEP level, and then you would get a joules number for the work to trigger, or for at least that which was occupying under the baseline. Now, of course, that was for a single move, a single breath, and of course, frequency had to be added into that to look at a work rate. But yeah, that's kind of how the vents did it. Graham, do you agree on that?
Sure.
Your experience, yep.
Yeah.
And of course, again, that doesn't account for eccentric work or synchronous work or work where the eye time has elapsed and the patient is still wanting a breath. All those kind of things are clearly not in that calculation.
My question really relates to the use of, which has become the use of a pressure support mode on a very low level of pressure support on a spontaneous breathing patient, which we were taught, and based on some work by Sashi Bhatt, that was imposing a work of breathing on the patient that was not natural, and they were taught that a pressure support of 5 or 6 was sort of necessary to overcome the work of breathing imposed by the circuit. Now, it's become, not, I wouldn't say common practice, but a number of people are now using zero pressure support. And my concern is that during that time, the patient is doing more work of breathing than they would be if they were extubated. And in fact, we're imposing a respiratory load on them, which according to, well, you know, the stuff we looked at before, that means they're doing an exercise, like Jeff running up this hill. He's going to get knackered, breathing harder now than he would be if he's extubated. I just wondered what the current thinking was on the use of low levels of pressure support or zero pressure support in patients who are spontaneously breathing on a valve circuit as opposed to a T-PICS.
And sorry, Ross, have you got an automatic tube compensation in that?
Well, that's the other question, with the automatic tube compensation, which accounts for the work imposed by the tube, but not by the circuit itself. So, yeah, whether you add that or not, it's a different matter. They're two slightly different things, but one adds to the other. Obviously, you've got tube compensation, you're overcoming the work imposed by the tube, but not by the circuit itself.
So we hope that the algorithms we have in our modern ventilators during the calibration routine accounts for the compliance of the circuit and the resistance of the circuit, such that the parameters we show you on the ventilator are trying to be reflective of the patient Y, of essentially the pressure or flows or volumes at that Y. And again, it depends on the ventilator itself, but I've rarely found a well-calibrated ventilator didn't adequately reflect at least pressure or volume correctly at the Y. And then, but you did raise an interesting question. What do you do with the single limb circuits, the valve circuits, not the dual limb circuits on some of these other ventilators? And should it be a practice of adding PEEP or pressure support to help overcome that imposed work of the endotracheal tube?
I can't understand why, Ross, why people would probably want to put somebody on CPAP, because what you're talking about, isn't it? With no pressure support?
Yeah, essentially that is CPAP. And it's just, you know, the original study was done on a Servo 300, I think, where there wasn't either tube compensation or I think it was done on a pressure trigger mode rather than the flow trigger. So there wasn't a flow-by circuit. So there are a whole lot of things that are different from what we do now. But I've not been satisfied that there is the data supporting that. There's one Canadian paper I could find, and it wasn't conclusive. It seemed to suggest that you could use a low level of pressure support with tube compensation, you know, 0 or 1, and that was a reasonable thing to do, but there's no outcome data with that. The concern I have is that we know that when we're weaning, if we exhaust patients, if we make them tired, we need to rest them for 24 hours. So we put them on a mode like this for 4 to 6 hours and become exhausted. Then we have to step back for 24 hours and give them full support to allow them to recover. Like Jeff getting to the top of the hill, he has to take more than a 2-second stop to recover. Probably takes 2 or 3 weeks for Jeff to recover from that. But knowing the size of the hill, it's not surprising either. But it's, you know, if you do exhaust yourself, you can't suddenly just say, that's fine, we'll give you a 20-second rest and off we go again. You need to have a decent rest. So if we're using this as a weaning strategy, we need to think carefully about what we're doing and what load we're imposing on patients.
So Ross, I think you might recall a few years ago, there was some paper or some article that described from an American university of these very fit guys, athletes, that were given resistive breathing, right? They were made to work with, imagine like a size 7 ETT, right? And they pushed them and pushed them, and they measured their diaphragm function. And basically these guys were, they lost, and these were fit guys. It took like 1 or 2 weeks to get back to where they were again. Can you recall that?
No, I know there was some work on exhaustion that I read it'd be 8 to 10 years ago. That's the similar story. Once you're exhausted, unless you have a decent downtime and recover, you're going to go into mechanical exhaustion very quickly afterwards. And
Yes.
as we all know, if you run a marathon, you can't go out the next day and run very far at all. And that's not just aches and pains, that's muscle strength is gone. And I think with the weaning, that's what we're trying to avoid, is exhausting patients during the weaning phase. It's difficult. And so what level do we need? What level of support do we need to prevent that happening, is really what I'm asking. Our usual way is to lower the pressure support slowly over time. But at what point do we think we can turn the pressure support off and not have any other support? I mean, we thought it was 5 or 6, but I'm hearing different things now.
Patrick, what do you think?
Yeah, we are so far a little bit reluctant to jump to turn off the pressure support. I think we have other reasons for that, meaning that we want to get it right, if possible, the first time, because once the patient leaves the ICU, that place will soon be occupied and we may not be able to come back again. So that's for a different reason. We are much more cautious about turning off the pressure support.
You have too many volunteers, do you?
Something like that.
We've not been using zero pressure support. I think the lowest we'll ever go to is 8 pressure support. But I must say, we've been doing more and more is using proportional assist ventilation while we're weaning the patients. So we tend to go down to 30 or 40% support, and then we'll do a spontaneous breathing trial on 20% support before extubating. My sense is I tend to have a better sense of how the patient's going to do after extubation with that mode.
I'm glad to hear that.
So Matt, that'll be a whole new discussion on weaning.
Or on PAV. Maybe we can get Magdi to join us.
That's right.
Yeah, we're using PAV a lot.
Can I ask one question before everyone heads away? And you touched on it, Steve, earlier when we began the conversation. It's mechanical power, and I'm struggling with the whole term, not necessarily the mathematics of it. I can sort of work my way through it, but just as a concept and this belief that somehow is going to give us a lot more information about ventilator-induced lung injury. I've got a paper by Jack Noni's the last author, but this is called Mechanical Power at a Glance, a Simple Surrogate for Volume Control Ventilation. And this is by Lorenzo Giosa and Mattia Usana. I don't know if you know these people. Essentially, a very nice simplified formula, but it doesn't take into account the issues that Marcello Matos talks about, which is the regional lung mechanics and the P-silly that we've often talked about, which I believe is the real problem. So when we talk about mechanical power, it still is a surrogate that's based on what the ventilator is spitting out, and the data that the ventilator spits out and displays on the screen is not actually ever going to tell us about regional lung strain. So that's why I have never been interested in trying to understand it better, because I really don't think it's ever going to tell us what we really want to know. But I'd like other people's view on it, because some people will have some strong views about using mechanical power.
So Jeff, not to try and drive this conversation, but one of the things on the monitoring I was going to try and cover was mechanical power and driving pressure, right? Because they tend to be things. I think we could do this again, don't you? Because this is actually going to probably be something by itself. Ross and I have been involved before with mechanical power before, so maybe that's another discussion we could have.
Jeff, I have similar reservations and other reservations about its ability to tell us much about what's happening in the alveolar generally, and in particular, as you say, in some alveoli where the damage has been done. I don't think we've got a number that can tell us what's going on in the alveoli at risk, which is what we're concerned about. I think the problem with our ventilation is we have one tube and therefore one pressure and flow that we can measure at any time. And we have 300 million alveoli, which unfortunately about half are not working, but that's we're trying to use one number to average out what's happening there. I think that's one of the issues we've got. So when you apply a pressure, you're averaging that pressure across all the alveoli, and the same with the strain and everything else. So,
Ross,
sorry,
I was going to say it's the same thing. Is the actual calculation correct?
No, I don't think it is.
No,
most of the energy is expended in the upper airways, and I haven't seen ALS the upper airways for many years. In fact, I don't think I've ever seen it. So,
I agree with you, Ross. And there's another problem I have with power, and maybe I just don't understand it, which is probably not likely that problem, but they conflate. So there's joined together two concepts. They have both the static elastance and the dynamic elastance all put together. And if you've got a static thing, because PEEP comes into it, PEEP is only applied once and that's it. And I've read sort of people saying, well, PEEP causes descending pressure and it's pressure initially required to overcome its initial pressure to inflate the lungs. But why does the PEEP come in, which is a static thing, come into calculating power, which is dynamic? It doesn't make sense to me.
that's Steve standing in the corner holding his chair in the air, isn't it? Isn't that what the PEEP is? That's the energy, isn't it? The power.
Yeah, I'm just deconstructing. I love deconstructing equations to see whether they make sense, and even if do a units analysis of it as well. Sometimes you find that they don't.
Well, Jeff, that may explain a lot.
I derived the power equation from Gatinoni's one a couple of years ago. I sat down for a couple of hours and figured it all out, and then I've now forgotten it. But I'm just sorry, I'm not convinced that the maths, the assumptions, the maths is correct. Algebraically, it is correct. I don't doubt it. But I just think the arithmetic assumptions in it are wrong. And I also think that the fact that you can't take into account regional strain within the lung, which is really what the problem is means that I think it's got limited utility. So yeah, that's a very arrogant statement from me.
Well, hold that thought, Jeff.
I will. All right. Thank you very much, guys.
Again, thank
Thank
you guys. I appreciate your time. Breathe easy and everybody stay safe.
Thank you.
Thanks.
Right.
Bye.
Thanks.
Bye-bye.